Welcome to the Expert Series, brought to you by the Lupus Foundation of America. Our health education team is here to bring you experts in lupus to discuss topics to help you live better. Thank you for joining us for today's episode. My name is Melissa, and I'll be your host. Our topic today is lupus and fibromyalgia, and my guests are Dr. Peter Izmirly and Dr. Kelly Corbitt. Dr. Izmirly is a professor in the Department of Medicine at New York University Grossman School of Medicine and co-director of the NYU Lupus Clinic. He is a rheumatologist whose research interests include lupus, lupus nephritis, and the epidemiology of lupus, among other topics. Dr. Corbitt is an assistant professor of clinical medicine in the Division of Rheumatology at University of Miami Miller School of Medicine. She treats all diseases within the field of rheumatology and sees many patients who have secondary fibromyalgia along with an autoimmune diagnosis. She also has an interest in connective tissue disease and associated interstitial lung disease. Thank you both so much for being here. I'm excited to learn more about lupus and fibromyalgia. We hear from a number of our constituents who have both of those diagnoses, and we hear from them that it's a very challenging situation to manage. So I have a lot of questions for both of you, so I just want to get started. I always like to begin at the beginning. So my first question is, can you define fibromyalgia? Tell us what it is and how it's different from lupus in terms of symptoms and causes and diagnosis.
Well, fibromyalgia is a chronic pain disease, and it's been around for many, many, many years, but it's only recently getting recognition. It is frustrating for a lot of patients because there is not a lab test, a blood test, or an imaging study that can tell us that someone has fibromyalgia. So instead, it's based on clinical criteria that have been updated most recently in 2016, and that relies on widespread pain, basically on both sides of the body, above and below the diaphragm. And it's not just joint pain, whereas people in lupus can get a lot of joint symptoms. Fibromyalgia affects a lot of different parts of the body. In addition to that, it comes along with some frustrating symptoms such as fatigue, waking up unrefreshed in the morning, having depression, headaches, lower abdominal pain sometimes is in the criteria, and having brain fog we hear quite often too.
So it sounds like a lot of those symptoms, though, overlap with symptoms of lupus. So does that make it really challenging to diagnose fibromyalgia in people with lupus?
Yes and no. I think Kelly brought pain to our clinic and helped us have a sort of a better way of processing our patients who have fibromyalgia. And I think, you have to look at the patient and look for, like, a patient who comes in with sinusitis and pleuritic chest pain or inflammatory arthritis that's caused by their underlying lupus. I would not label that person per se as having fibromyalgia at that time. I feel like their disease is active and not being, in need of immunosuppression to treat their disease. But in some percentage of of patients, and in our paper, I think it was 17.4% of patients, there is an overlapping fibromyalgia in which we cannot detect any evidence of serologic or inflammatory activity on exam, but yet they have a lot of the symptoms that Kelly is describing. And I think those patients, if they fulfill our criteria for fibromyalgia, I would feel comfortable labeling as having such.
Okay. So you mentioned your paper where you found that 17% had people with lupus also had fibromyalgia. So that's almost 1 out of every 5 people with lupus. So that's a pretty significant portion. Can you say why do you think that it is that common for people with lupus to also experience fibromyalgia? And then what's the impact on somebody's quality of life to have that second diagnosis or that second condition on top of lupus?
This is $1 million question because
We wrote a grant to try and figure this out, which was not funded.
I think that there are probably several ways that the syndrome of fibromyalgia comes about. And I think that this makes it so challenging to study and get better treatments for patients because it's probably more than one way that somebody can get the syndrome of fibromyalgia. So there are some early suggestions in some papers that there may be an autoimmune component to the disease. So if that's the case, it's not crazy to think people with one autoimmune disease could get an autoimmune problem from another thing. But it's not so teased out in the way where we understand what degree that autoimmune problem is potentially doing, because we do know that fibromyalgia doesn't respond to medications that suppress your immune system like other autoimmune diseases do. The second thing is that we think there is a proportion of patients that get fibromyalgia from basically the body being overwhelmed with pain and not knowing how to process it correctly. So it ends up being this pain processing problem where the brain is constantly interacting with the center of the brain that creates the sensation of pain. So your brain at rest should not be talking to the pain center unless you had a cut or you just had surgery or something. But in fibromyalgia, that can happen. And then we also think that for some reason, the brain is less able to turn off the sensation of pain. And this could sometimes happen if somebody has pain for a long period of time. So since not everyone gets diagnosed with their lupus immediately, or some people have very difficult to control lupus, it's possible that real kind of pain that we can see on a physical exam, like the joint is hot, swollen, can't be moved, that kind of thing, could contribute to a central kind of brain nerve processing problem with the pain.
Okay. So I'm just going to ask a really basic follow-up question. Fibromyalgia is then not considered an autoimmune disease?
Not as it stands right now, but it is well understood that it occurs far more commonly in autoimmune diseases, with lupus being a large one, but also in other autoimmune diseases, rheumatoid arthritis, psoriatic arthritis, different ones in the immune system than it does in the general population. It's probably 1% to 2% of patients or of, our population.
Yeah, so that is a big difference. So because of this link and the fact that there are so many overlapping symptoms, and when someone with lupus, when they're having a lupus flare and their symptoms start to build, if they also have fibromyalgia, how can you tease out which one of those is causing the issue, and how does that affect your treatment approach?
So that's a very good question, and I think it starts with being a good clinician and doing a physical exam and assessing for evidence of activity causing the pain on the exam. So if you have, as Kelly mentioned, and arthritis on exam, inflammation, swelling, difficulty making a fist, or evidence of serositis, or another reason to cause pain on exam that we feel is part of their underlying lupus activity, that would suggest that lupus activity is contributing to the pain. But in patients with fibromyalgia, from my clinical experience, their exams tend to be normal in many ways, and that they do have a history of lupus, but on exam, I don't see any activity that I can discern on with my limited capabilities, right? I mean, we don't have sort of like portable MRIs where I can look at their joints and see subclinical information that I might be able to detect with my clinical exam. So let's just assume my clinical exam is accurate. And also, in theory, you look for serologic lupus activity, other signs of lupus activity like kidney disease. I mean, that would require, obviously, treatment for their lupus, where I think in fibromyalgia, there's no really discernible activity on exam, and I wouldn't want to subject those people to unnecessary immunosuppression in any form, because they do obviously carry risks, but they're obviously necessary when activity is detected. And they might benefit from treatments which are pretty primitive for fibromyalgia.
So what is kind of your baseline treatment then for fibromyalgia? If you determine that someone is not in a lupus flare, but they come and they're in a lot of pain and they're having these other secondary symptoms like brain fog and fatigue, what can you do for them?
So the FDA has 3 approved medications for fibromyalgia, but you will see others being used as well. The two medications that are FDA approved that are often utilized are duloxetine, which the brand name is Cymbalta. That works by increasing something called serotonin and norepinephrine. Because of that, it was originally a drug for depression or anxiety, but those two, what we call neurotransmitters, those two molecules in the brain actually play a big role in that pathway that tells the body to turn off the sensation of pain. So when we increase those, we can help if the body is not getting enough signal that the pain does not need to be there. And the other medication is called pregabalin, or Lyrica is the brand name for that one. That one works in a different way. A lot of times that's given for nerve pain. And I do think that there's some people that probably have something called a small fiber neuropathy, which is where the teeny little nerves in the skin are a little bit damaged. And both medicines could help with that too, but this one helps with nerve pain and it's given for that a lot. It also helps by decreasing the connectivity between those two areas of the brain I was talking about. So that rest area of the brain and the pain area of the brain, it kind of stops them from talking so much at rest. And that's how we think that that works. You'll also see providers use gabapentin, I think, which is a nerve pain medicine. I think that's because providers have a lot of experience with it, but we actually don't have a lot of data on it. And the data that we do have, you need quite large doses to make a difference. Amitriptyline, which is originally an antidepressant, is also used sometimes. Sometimes I find that has lower side effects than the other ones. So there's a lot of medicines, and then non-medical therapy. There is a lot in pain psychology people can work with. People are looking at biofeedback mechanisms and how that can work. Exercise helps fibromyalgia, but only if it's consistent exercise. So it'd be hard to tell somebody who hasn't exercised a day in a year to go out and go do exercise and expect they're going to feel better the next day. They'll feel better once it becomes consistent because it works in the same way of modifying how the different areas of the brain talk, but it doesn't work on a one day you exercise, the next day your fibromyalgia feels better.
I would also speculate that if those drugs do help, my impression is if they do work, it's acting in the brain, and even if it's being given for the peripheral nervous system. But that's me speculating. I have absolutely no substantive data on that.
That's probably true. Those mechanisms make a lot of sense why they work, centrally in the brain.
So I want to follow up on the mental health aspect of it, right? Mm-hmm. So you said that a couple of the drugs that can work with fibromyalgia were originally used as antidepressants. I know that in people with lupus, anxiety and depression often come along with that disease and are comorbidities. Is this also true of fibromyalgia? And what is the mental health dimension?
Yeah, this is a great question, and it's a bit of a chicken and egg question, as it probably is for things like lupus too. So depression is part of the criteria even, or part of something called a symptom severity scale in fibromyalgia. So we know anxiety and depression are very, very prevalent in that disease. It's hard to say if that is because people are living with chronic pain and that causes that to some degree, or whether that came first and it contributed because of the changes in the brain that depression and anxiety have to getting something like fibromyalgia. I will caveat that I talked about the two ways in lupus fibromyalgia may come to be. There is probably a third sector of this that's more driven by an untreated mental health sphere. That's shown on what we call functional MRI studies, where they're able to look at how the brain lights up while somebody is awake and having different things, pressure points pushed, whatever it might be. The people that had more active or untreated mental health had different areas in the brain light up in response to pain than those that had depression, anxiety, but it was more treated or kind of milder symptoms. So it actually may be kind of a third way that fibromyalgia comes to be. And in those patients, I would urge getting appropriate mental health treatment too, so we can modify that component, help that component, and then see, what areas need to be worked on after that. But certainly any chronic disease, whether it's fibromyalgia or lupus is a tough thing to deal with. Utilizing our mental health resources are really important.
Yeah, yeah, and for sure. And I definitely hear what you're saying about the chicken and the egg, right? We know that as well. Do people get depressed because they have lupus, or is the lupus a symptom, or is the depression a symptom of the lupus? It gets really hard to sort of untangle where one thing ends and another begins. And so I want to take a slightly different then in asking my next question, although it does have to do with mental health and pain and, chronic illness. And that is, what have you found in terms of what ways do like cultural and ethnic differences influence the perception of a pain syndrome like fibromyalgia, or the reporting of it? You know, how do pain is a really personal thing, but the way that we talk about it and react to it is really influenced by the culture around us. So, can you talk a little bit about that, how that influences people's experience?
This is somewhat tricky, but because I don't know what and maybe Kelly does, like the demographic breakdown, because each disease sometimes for a variety of reasons, societal, environmental, or, doesn't affect each demographic at the same way. I mean, as no, lupus is 9-to-1 female to male, and Native Americans and African Americans and Hispanics have the highest rates, based on some of the CDC epi work that my colleagues and I have done. I mean, we are one of the advantages of the study that we did is that our NYU lupus cohort has many of the demographics very well represented. So we were able to see differences in the demographic study. Now, I don't know if that has to do with cultural or genetic or environment, but we did see that, and I'm pulling the paper up just to make sure I don't misquote it because I can't memorize all the stuff. But if I remember correctly, Asian lupus patients in our cohort were less likely to have fibromyalgia, and I think that was correct, right? Yes. And that was actually, again, numbers weren't gigantic, but and I'm sure there could be some power issues, but it was a significant difference in that lupus patients were less likely to have fibromyalgia than the other demographics in our cohort.
Yeah, and I guess I would add from a not as sophisticated kind of way here. I think culturally, not necessarily one ethnic group or the other, but I definitely see that some patients don't feel comfortable always talking about their fibromyalgia or the level
Yeah.
of the pain. So that's a component for sure, like how comfortable someone feels in their different doctor's appointments. And then I also see sometimes that family members will help a patient kind of tell me their full symptoms. So sometimes a patient will come in and say they're feeling fine, and it's because they're feeling, I don't know, 25% better, but their family member will say, "Why don't you explain to her what you've been having going on every day," and kind of encourage that a little bit more. So I think it's just someone's likelihood to advocate for themselves, or a family member's or friend or whoever it might be, helping them advocate for themselves, but that's variable culture to culture. And I think that there's some, obviously we know that unfortunately those with a lower socioeconomic status have higher rates of fibromyalgia, and that was shown in an abstract at the American College of Rheumatology recent meeting this year. And it's been reported in the past, and that may be due to lack of care in general, or potentially lack of resources. If you have less mental health resources, if you have less resource to get treatment when your disease is active and you have ongoing pain, like we talked about, for a longer period of time, that could explain that a little bit. We know that although not directly definitely causative in any way, sleep is a big component of pain. If you have to work more hours, you're less able to rest. You're not able to get a CPAP if you have sleep apnea. There's a lot of other things that kind of play into this too.
Yeah, and so that then brings to the other part of sort of cultural type effects. And you had mentioned this earlier about exercise. How important are lifestyle factors like diet and exercise and your stress level and how much you can sleep and and even some of the you mentioned social determinants of health. I mean, I don't think you said social determinants of health, but that's what you're talking about. Lower income folks, those types of things that kind of affect our overall health. How important are they in dealing with fibromyalgia?
I think they're incredibly important. I will caveat this by saying I have privileged and unprivileged patients with fibromyalgia, and I have fit patients with fibromyalgia and unfit patients with fibromyalgia. So I don't think that if we say, exercise, lose weight, sleep well, it's going to completely make no one have fibromyalgia. But we know regular exercise will lessen the pain of fibromyalgia for sure. We know having poor sleep will worsen the pain of fibromyalgia for sure. So those things are very kind of clear cut lifestyle things that are going to affect a patient in one way or the other. I think that having excess weight, we know contributes to things like osteoarthritis, worsen pain, and those kind of conditions. And that can exacerbate fibromyalgia pain or confuse fibromyalgia pain or have some other stuff go on there. I think that having a healthy diet's important. Some people look into omega-3 versus 6 ratios in autoimmunity in general. I think is the only diet that's been reasonably studied, which is essentially a Mediterranean diet. Of course, if you have more resources to eat better food, you're going to feel better. All of these things definitely, I do think, play a decent role here.
Yeah. And I mean, I think they do in chronic illness generally, but
Mhm.
yeah, it's interesting to see how that kind of goes across everything. So when you're thinking about when a clinician is trying to kind of learn a patient's lived experience, what is the role of kind of these diagnostic tools? And I have them written down, the 36 vitality scale and the facet fatigue scale. Are those the types of things that you use with patients to kind of quantify what they're feeling? Because it's really hard to express pain. They tell you, give it a number, but even the numbers don't always, it's not the same across people, right?
I mean, we've been using the fibromyalgia scale since Kelly was a fellow with us and started bringing it to our clinic, and our coordinators have now continued to assess it over time. So we do use that as a way to sort of assess their degree of pain and symptoms and how they're overall doing. And again, I think it's important to go back to to make sure that there's no lupus activity contributing to this and that we constantly do that. So I think it's definitely in large part thanks to Kelly, more on the forefront of our clinics now in terms of assessing for this.
Yeah,
I think it could be helpful. A lot of these are helpful research tools and looking at how interventions help or don't help. Obviously, it's hard because even the tools are asking about personal experiences that are hard to quantify or might be influenced by a lot of different factors. But I do think in the future, more researchers in lupus or in other autoimmune diseases adding in these measures could help us understand secondary fibromyalgia as a whole, seeing the trends, even if a study is not directly related to that, just seeing the trends of how somebody's symptoms may rise or fall or change over the course of treatment for their immune disease in general.
So that brings me to my next question, which is about recent advancements in research. Treatments, treatment options. So is there anything that you're excited about for people who have both lupus and fibromyalgia that you think might be really helpful, or is it, still pretty early stages in figuring out the best way?
I would say it's still pretty early stages because as far as I'm aware, there's nothing new on the horizon um in that area that's specifically treating fibromyalgia pain, but Kelly may be more up to date on that.
Yeah, I think There's little things here and there. There's been a study on nighttime sublingual cyclobenzaprine that seemed to have efficacy in fibromyalgia. This wasn't specific to lupus and fibromyalgia, but we've been using cyclobenzaprine to some extent. I haven't used the sublingual formulation or in the way that this study did, so I can't personally speak how well or not well it's worked for my patients. That was really recent, but I think that you will see a big change in fibromyalgia when we can either find a biomarker or find, which means like a blood test, or find some type of way to tease out the underlying thing that's causing the syndrome of fibromyalgia. A lot of times we have kind of incongruent findings in fibromyalgia research. And it may be if more than one process is really driving, the fibromyalgia symptoms in different people, that until we find, a reliable objective marker, it's going to be hard to put the right people into the study or know who to give what treatment to.
As you were speaking, my brain popped in, maybe it's slow, that there was some data about vagal nerve stimulation reducing pain in like a pilot trial by like Cindy Aronow. So there are sort of like interesting avenues to try and address this topic. And this paper we did was in lupus patients. So I don't, if I remember correctly, I wouldn't anticipate that it's working is unique to lupus patients.
Yeah, and I will say that over the past couple of years, the pain community as a whole has taken this type of pain, which is called nociplastic pain, which is more central pain processing problem than a cut or a burn or something that you could see. But I think not even just unique to fibromyalgia and lupus, but the whole pain community is a little bit more interested in this type of pain. So hopefully we'll see more advances now compared to even, 20, 30 years before now.
And do you think that that is possibly just because people are starting to take pain more seriously? And so do you feel like that clinicians are starting to take that into account a little bit more?
Yeah, I think yes, as a whole, for sure, yes, in our community. It's still going to be very physician to physician and how comfortable they are talking about fibromyalgia or treating chronic pain. We even have some small data that a patient understanding what's happening in their body with fibromyalgia helps the pain a little bit, because it can get really confusing when you have a central pain disorder like this, knowing what you need to pay attention to in a even survival kind of aspect versus what is your brain kind of sending inappropriate pain signals. So I think that if the doctor is comfortable discussing fibromyalgia and what it means and how it's affecting the patient and how to go about treating it, I think that you will get more doctors really kind of paying attention to it and taking it seriously. But there's still some people who I think don't have the comfort level yet.
I think it's in part because there are really, you want to help treat something that has effective treatment, and we're still pretty far behind in that department, right? And you could say the same for lupus, although we've made a lot of headway over the last decade. But having effective treatment makes it easier for a clinician to sort of ask and inquire about some of these issues, because then they feel like they can give something for it.
And I think with fibromyalgia, not having a blood test or an imaging study that you can do, it can be hard too for a clinician to eventually decide this is fibromyalgia, because you really have to make sure it's not something else that has a different treatment. But I think that can be frustrating to patients too if they keep getting tests with no answers.
Sure, especially if they're in a lot of pain and can't really get an answer or an effective treatment. So that brings me to my last question, which is, if you were giving advice to patients, which you are, how would you advise them to advocate for themselves? Or even if someone is listening to this and thinks, you know what, I think I might have fibromyalgia, but I never knew how to describe it for my doctor. What would your advice be to someone who is in that situation?
I would say don't be afraid to ask your doctor if they think you could have fibromyalgia, if that's part of the possibility. I think when it comes from the patient, maybe it opens up the conversation a little easier because doctors don't want to feel like they're dismissing complaints either by not appropriately working them up. So I think the patient asking is a good way to do it. I usually give my patients the National Fibromyalgia Association website, which is FM, like the letters F, the letters M, aware, like you're aware of something, AWARE.org. It has a lot of good resources on there. It goes through fibromyalgia quite well. So I think if you come to your doctor saying, hey, I've read other patients did well with this medicine. Do you think we could try switching from gabapentin to Lyrica? It may be an okay thing that maybe your doctor didn't even think to ask you about. So a lot of it is looking into what's out there, what other patients are experiencing, using resources that are well vetted, like the foundations and organizations for these diseases, and then having an open conversation with your doctor.
That's great. That's great advice. And we'll be sure to include that link in our show notes for our listeners so that they will have that. So I think this is a great place to end. I so appreciate your time. Thank you for talking with us about lupus and fibromyalgia. I've really learned a lot today, and I hope that our listeners have as well. So I invite those of you listening to check out past episodes of the Expert Series by visiting lupus.org/the Expert Series, where you can also subscribe to get alerts when podcasts are released. If you have any lupus-related questions, please reach out to the health education specialist by email at lupus.org/healtheducator or by phone at 1-800-558-0121. And we'd love to hear from you about other topics of interest. If there is a topic you'd like to see covered on the Expert Series, email us at info@lupus.org. That's info@lupus.org. Thanks again for joining us. And thank you again, Dr. Izmirly and Dr. Corbitt. This was great. I really appreciate it.
Thank you.
Thank you.